Okay, so let's start with the session. So, yeah, all fine. Okay, so am I audible? Is the screen clear so that we can start the session? Everyone, is the screen clear? So, I hope the anatomy MCQs of the FMG exam was easy because many of the direct MCQ has been asked and repeated topic has been asked. So, कंपैरेटिवली अगर बात करें तो एनाटॉमी के क्वेश्चंस इजी थे, तो मोस्ट ऑफ यू मस्ट हैव गिवन ऑल द आंसर्स आई फील. ओके, so let's discuss one by one. So we have got good evening everyone. So we have got I have altogether I am going to discuss 18 MCQs of anatomy subject, maybe correlated with the clinical subject. Okay, so many of the anatomy questions were correlated with the clinical subject. So there are questions from head and neck part, there is question from neuroanatomy, one question from embryology also, and one or two questions from embryology, and also lower limb and upper limb. So altogether I am going to discuss 18 anatomy MCQs. Let's start with the first MCQ. And in the first MCQ, a patient underwent Thyroidectomy, means removal of the parotid gland. Post-operatively, he complains of excessive sweating and redness over the parotid region. So where is the parotid gland located? Everybody is knowing it is located anterior to the ear. This is the parotid bed, and this is the area where parotid gland is located. So basically in the pre-auricular region, in the parotid region, there is excessive sweating and redness. Okay, while eating food. So when anybody is taking food or while eating food, excessive sweating happens in this area, which is given in the MCQ. So what is the diagnosis of the condition? So what have you written the correct answer? According to you, what you feel is the correct answer, whether it is Fraze syndrome, whether it is Horner syndrome, crocodile tear syndrome, or the first bite syndrome. So I think it's very easy. Let me just tell you about the keywords which has been mentioned here. The keywords is excessive sweating and redness over the parotid region. Okay, ये हमारा highlighted keywords है, which will help us to go with the most correct answer. Okay, now also it is related to the parotid gland. That means you have to know about the nerve supply of parotid gland. So we know that there are parotid glands, some mandibular glands, some lingual gland. They are major salivary gland, and there is parasympathetic innervation which is secretomotor, and because of that there is secretion from this parotid gland. Actually this condition is Fraze syndrome, and it's a common syndrome, has been asked so many times in the previous year examination. So let me explain this. So actually you can see this image and you can appreciate that just anterior to ear we can see here the parotid region. I have marked an arrow over the area which is red. Sweating is there, redness is there. So actually gustatory sweating is there. So what do you mean by gustatory sweating? While eating, and in this case the patient who experienced sweating and flushing over the parotid region while eating, actually there is involvement of auriculotemporal nerve. So it's a complication of parotid gland surgery. What happens, we know that auriculotemporal nerve is having the parasympathetic component, and it is very important for the secretomotor pathway of the parotid gland. But what happens if it is injured? When the regeneration occurs, they regenerate along with the great auricular nerve, and there is, because of this, we know that the area here anterior to ear is having sensory supply by great auricular nerve. So the regeneration of auriculotemporal nerve and regenerating in with the great auricular nerve is the reason why there will be redness and there will be flushing redness in this area when the person starts eating. So we are quite sure about the correct answer, that is Fraze syndrome. What about the other one? Why Horner syndrome is wrong? Why crocodile tear syndrome? And all of you, have you marked the right answer? Please let me know. Have you marked it right? Okay. So what have you marked? So I think you have definitely marked it right, and the correct answer here is the Fraze syndrome. I would also like to rule out the incorrect options. Now, Horner syndrome is not the correct answer. Why? Because when there is sympathetic fibers. When the sympathetic fibers are injured, when the sympathetic fibers are injured, this will lead to Horner syndrome. In Horner syndrome, the clinical features are also different. There will be drooping of upper eyelid, there will be constriction of people, and also there will be absence of sweating, that is called as anhydrosis. So basically these are the three primary abnormalities which will be found in the Horner syndrome. So obviously Horner syndrome is not the right answer. Okay, now coming to crocodile tear syndrome. Crocodile tear syndrome is also not the right answer. The other name for crocodile tear syndrome is, it is actually also called as Bocard syndrome, gustatory lacrimation. And in this case, what happens when a person shed tears while eating, drinking, or smelling food? So this is actually an aberrant regeneration of facial nerve. So what is the reason of crocodile tear syndrome? There is aberrant regeneration of facial nerve after the injury, and again misdirection of autonomic fibers of lacrimal gland instead of salivary gland. So this is also not the case because lacrimation word was not mentioned in the MCQ. So crocodile tear syndrome is also not the right answer. Now coming to the last option which was given, that is the first bite syndrome. What was it? It was the first bite syndrome. And when I am talking about this first bite syndrome, actually what happens, there is the reason of sympathetic nerve supply affected, that is supplying the parotid gland. So when the nerve is damaged, and we know that inside the parotid gland there is myoepithelial contractile cells. What is the function of this contractile cells? Squeezing out the secretions, okay, for formation of saliva and squeezing out. So because of that, what happens, the hypersensitivity to the parasympathetic nerve stimulation happens, and there is a exaggeration and painful contraction with the first bite will be unopposed by the sympathetic fibers. So as the parasympathetic nerves are unopposed by the damaged sympathetic fibers, there will be jaw pain with the first bite, and this is called as first bite syndrome. So clearly we can see all other options are wrong, and the right answer is Frey syndrome, which is already marked in this MCQ. So is it okay everyone? What is the right answer? Frey syndrome. Let's move on to the next MCQ, that is question number 2. Now, a patient presents to the OPD. Now, the next question is, a patient presents to the OPD with a complaint of ophthalmoplegia and ptosis. Okay. So, on examination, a diagnosis is made which is involving which fissure? The fissure which is involved is superior orbital fissure syndrome. So, what is the name of this syndrome? Superior orbital fissure syndrome. So what does that mean? That means the superior orbital fissure is involved. That means all the structure which is passing or traversing from the superior orbital fissure is involved. So basically, superior orbital fissure will have a circular ring inside, that is called as the annulus of Ginn, which is a circular ring which is giving rise to the 4 recti muscles: superior rectus, medial rectus, lateral rectus, inferior rectus. It will divide the superior orbital fissure into 3 compartments. And if you remember, we have already covered this cranial foramens, and I have given you the mnemonic, that is LFT, lacrimal frontal trochlear. All these are passing through the upper part of the superior orbital fissure. Then the structures are passing from middle part, and the structures passing below the middle part, that is outside the tendinous ring. So, if I talk about the structures passing, definitely the oculomotor nerve, upper and lower division is passing, definitely the trochlear nerve, and definitely the trigeminal nerve first branch. So basically, if I talk about trigeminal nerve, it is having 3 branches, 3 components: ophthalmic, maxillary, and mandibular. Among this, V2, what do you mean by V2? So here 2 options I will strike out. Why not V2? Why not V2? Any idea? V2 here means the trigeminal nerve second branch, that is maxillary nerve. That is maxillary nerve. And maxillary nerve passes through foramen rotundum. Maxillary nerve foramen rotundum से पास करता है, तो डेफिनेटली हमारे B और D ऑप्शन रॉन्ग है. D ऑप्शन रॉन्ग है. और यहाँ पे ऑप्शन C में second cranial nerve has been mentioned. That means optic nerve. And my dear students, this is also wrong because optic nerve passes through optic foramen. So basically optic canal. So basically superior orbital fissure के close में ही in the orbit there is an optic canal, optic foramen, through which the second nerve, optic nerve, along with ophthalmic artery passes. So definitely C option is wrong. So we have striked out B, C and D. The correct answer will be the oculomotor nerve, the trochlear, the ophthalmic nerve branches, yes, like lacrimal frontal is passing through it, and also the sixth cranial nerve, that is abducens nerve, is traversing through superior orbital fissure. So again, I would like to show you this foramen. So first thing, this is the diagram. Let me slightly enlarge it. So when I am enlarging it, what you can see the orbit from the frontal aspect. You can see the anterior aspect of the orbit, and different colors has been used for the bony outline, where you can clearly appreciate. So here, this retort-shaped structure is the superior orbital fissure, and close to it is the optic canal. And as I told you, from the optic canal or optic foramen, second cranial nerve passes, and from superior orbital fissure, third cranial nerve, fourth cranial nerve, sixth cranial nerve, and also the branches of ophthalmic nerve, which is the branch of V1. That is the branch of V1. That is the first component of trigeminal nerve passes, and superior ophthalmic vein passes, inferior ophthalmic vein traverses. So we have got the right answer, but I want you to know all the structures passing through superior orbital fissure. So this is a schematic diagram to make you understand. So as I told you, there is a tendinous ring which is giving rise to the recti muscle, and here it is dividing the superior orbital fissure into three parts. So from the upper lateral part, LFT passes LFT. What is LFT? Lacrimal frontal trochlear. Also the superior ophthalmic vein passes, and through the middle part or through the tendinous ring, the superior inferior division of oculomotor nerve, nasociliary nerve, abducens nerve, and through the lower part, inferior ophthalmic vein passes. So very nicely you can appreciate all the structure which is traversing through superior orbital fissure, and clearly if you have to mark the right answer. So what is going to be the right answer, my dear students? The right answer is option A, which we have already discussed, that is third, fourth, sixth and V1. Is it okay? Let's move on to the next. Any student is having any doubt, they can directly ask me. So let's move on to the next, that is the third MCQ. So very easy. What I feel that इस बार हमारा anatomy का paper बहुत easy था, and I think most of the things has been covered in the class. So 80 to 90% questions are from the class topics and notes only. Identify the nerve indicated and the clinical case in this given image. So basically we can see a blue color arrow is pointing to the location of nerve. So you have to identify that nerve and then proceed with the right answer. So basically, actually, when we talk about the posterior triangle of the neck, we have got a cervical point. From there, the four branches of the cervical nerve is fruiting in four directions. So here, great auricular nerve is the right answer. Why, I will tell you. Let me show the image for you. So basically, here we can see the sternocleidomastoid muscle. So let me just highlight the two muscles. Okay. So this muscle is sternocleidomastoid muscle. Okay, and this is the trapezius muscle. Okay, so we have got, so that means this triangular area is, so what is this triangular area which I have highlighted in green color? This is the posterior triangle of the neck. We have covered posterior triangle, we have covered all the triangles of the neck very nicely in our anatomy lecture. And after that, what you can appreciate that there is nerves, four nerves from the cervical flex is going in four directions. So one is the transverse cervical, which will go transversely. So we are not concerned with this. This is going transversely. If you want, we can slightly. Okay. Then we have got the one which has been asked. This is the great auricular nerve anterior posterior branch. So this is the great auricular nerve anterior posterior branch, and lower down we will have the supraclavicular nerves which will go lower down. So this is the supraclavicular nerve. This is the supraclavicular nerve. And lesser occipital nerve will also be there. This will be the lesser occipital nerve. Okay, this is the lesser occipital nerve. So what is asked in examination and what was the right answer here is the great auricular nerve. So you can appreciate the location of great auricular nerve, that is going upward around the area near the ear, and they have got anterior posterior division which is giving cutaneous innervation in this area. So if I have to mark the right answer, I will go with great auricular nerve. Got it? Okay, so the arrow marked area is at the location of great auricular nerve. Let's move. So great auricular nerve is a sensory branch of the cervical plexus. The root value is C2 and C3. It's very important that you should revise all the area of cutaneous distribution of great auricular nerve. So ये किस area को supply कर रहा है? It is supplying the skin over the parotid gland. Okay, okay. It also gives sensation to the area of the skin of mastoid process, the part of external ear. It also supplies it is having two branch, anterior and posterior. The posterior branch also gives innervation, excluding the upper part. It gives innervation to the posterior lower part of concha, and in addition, great auricular nerve will also give innervation to the skin and fascia over the parotid gland. So these are all distribution of great auricular nerve, anterior posterior division, and so the correct answer is the great auricular nerve. Let's move on to the next. So question number 4. So in this MCQ, what you can see, you have to identify the case. The option given is, here the option given is external, here the option is epidural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, intracranial hemorrhage. Okay, so here if you will see, the arrow is over the so actually this is a case of subarachnoid hemorrhage, and we know that subarachnoid hemorrhage is quite common in case of, it is common if they're in elderly hypertensive patient, and here mainly the aneurysm rupture occurs. So the aneurysm is formed in the anterior communicating artery or at the anterior cerebral anterior communicating arteries connection. So we will have subarachnoid hemorrhage as the right answer. So the CT scan image which was shown in the MCQ is showing you subarachnoid hemorrhage. So it is in the form of whitish area in the center, as you can see, which is traversing in lateral direction to the sulci on either side. So subarachnoid hemorrhage results from head injury, and the most common reason of subarachnoid hemorrhage is the rupture of cerebral aneurysm, rupture of berry aneurysm, and aneurysm are quite common in the circle of Willis, and mainly it's involving anterior communicating arteries or the bend of anterior cerebral anterior communicating artery. So in this case, and mainly the clinical history which will be given for the patient will be elderly hypertensive person. So see here, we have already talked about the difference of subarachnoid hemorrhage and that of epidural hemorrhage. So basically, we have got the right answer, that is subarachnoid hemorrhage. Now, my dear students, let's move on to the next MCQ, that is MCQ number 3. Okay? Any of the students is not understanding anything, they can let me know. Okay? Now, question number 5. A nerve conduction study is being performed as shown in the image. As you can see, nerve conduction study has been done. Electrodes are placed in the wrist and stimulation is given to assess the motor and sensory function. So you have to identify which is the nerve being monitored, whether it is the radial nerve, whether it is the median ulnar or axillary nerve. So here what you can see, the electrodes is placed in the medial side. What you can see, it is placed on the medial aspect, and we know that medial nerve is laterally and ulnar nerve is medially. Ulnar nerve is passing superficial to flexor retinaculum when it has to traverse in the hand, and the medial nerve is passing beneath the flexor retinaculum. That area is called as carpal tunnel. And here we have to also so basically by the location we are quite clear that the nerve being tested is the ulnar nerve. Okay, so it's also very important that you should have an idea of the course of the ulnar nerve when it reaches. So basically, it is passing above the flexor retinaculum, which is also called as transverse carpal ligament. And ulnar nerve is covered by one of the superficial slip from the transverse carpal ligament, which is called as the volar carpal ligament, and that space is called as Guyon's canal. So here you can see I have just included this. This is the deep branch of ulnar nerve. As you can see, the palmar branch is passing more superficial, and deep branch will traverse, and ulnar nerve is giving innervation to hypothenar muscle medially. Okay, so that means electrode which is applied on the medial side of the hand and the wrist is testing the ulnar nerve, and ulnar nerve will supply the muscles of hypothenar region, that is abductor digiti minimi, flexor digiti minimi, opponens digiti minimi, and will also give sensory supply over the medial 1.5 finger, both on the palmar and the dorsal aspect. So it's quite clear that the ulnar nerve will be the right answer. Here in this diagram, you can clearly see this is the ulnar nerve, and this will pass superficial to flexor retinaculum, and ulnar nerve is covered by a volar carpal ligament. So basically it passes through which canal? It passes through Guyon's canal, both ulnar nerve and ulnar artery, both ulnar nerve and ulnar artery. Okay, so clear. So here I would like to show you another image where you can see ulnar nerve giving innervation to medial 1.5 of the palm and 1.5 of the finger, both dorsal and on the palmar aspect. So this diagram, why I am showing you this diagram is important to appreciate the cutaneous distribution, sensory supply on the palmar aspect and on the dorsal aspect of the hand. So what we can see, the cutaneous branch of ulnar nerve giving innervation on the dorsum of hand, and here we can see the palmar cutaneous branch of ulnar nerve giving innervation to the palmar medial side of the hand, and also here you can see the medial 1.5 finger, both on the palmar and dorsal aspect, is supplied by ulnar nerve. Okay, you can see the lateral. Here you can see the lateral part. If you will see the lateral part of the palm, lateral 3.5 of the palm and the fingers on the palmar aspect is supplied by median nerve, and the median nerve on dorsum is supplying 3.5 nail buds, only the nail buds. And rest area, if I talk about the rest area is supplied by radial nerve. So this diagram is clearly showing you the distribution of nerves on the palmar dorsal aspect of the hand. Let's move on to the next MCQ. So this is an easy one, and I think most of you must have marked it right. What is the root value which is affected in the given image? C4, C5, C5, C6, C7, C8 and C8. So it's very easy. Actually, this image is showing you a decode paralysis, and here upper trunk of brachial plexus is involved. So this is a case of upper trunk brachial plex injury, and we know that in case of upper trunk of brachial plex injury, the arm is hanging by the side. So arm जो है वो hang करता है by the side. So arm will be medially rotated and adducted. What is the position of arm? Medially rotated and adducted, and the position of forearm is, as you can see in the image, it is extended and pronated. It is extended and pronated. So it feels like someone is asking money from behind. It feels like someone is asking money from behind. So it is also called as policeman tip deformity, waiter tip deformity. It is called as Erb's Duchenne paralysis. And upper trunk of brachial plexus is injured or damaged. And we know that upper trunk of brachial plexus has got the root value of C5 and C6. So definitely the right answer is B, C5 and C6. Now see here. So here you can see one side Erb's palsy has been shown, another side Klumpke's paralysis has been shown. In Erb's Duchenne paralysis, C5 and C6 is involved, and in case of Klumpke's lower trunk brachial plex injury, C8 and T1 is involved. Now the position of the arm and forearm has been already explained, and we know the arm is adducted and medially rotated, the forearm is extended and pronated. And in case of lower trunk brachial plex, so upper trunk brachial plex injury, C5 and C6, lower trunk brachial plex injury is C8 and T1 root value, and the person will have medial claw hand. Claw hand. What do you mean by claw hand? The metacarpophalangeal joint will be extended, and if we will talk about this is claw hand, the metacarpophalangeal joint is extended and interphalangeal joint is flexed. Is it okay? So, and if I have to appreciate exactly, we are seeing claw hand in which of we are seeing claw hand where. So the right answer is claw hand is appreciated in the medial part. That is, medial claw hand will be the right answer in case of lower trunk brachial plex injury. And the case which and the image which was shown was upper trunk brachial plex injury. So the right answer is C5 and C6. Okay. Okay. Let's move on to the next. Question number 7. A patient presents with a history of long bone fracture, the femur or the humerus. Okay. A few hours, so there was an image where the fracture of the shaft has been demonstrated, long bone, femur, humerus, the middle part has been only shown. And after the injury, few hours later, the patient develops breathlessness, tachypnea, confusion, and what is the most probable diagnosis? Okay, so basically breathing at a faster rate. So basically, if we talk about this condition, generally it is the complication of fracture of long bones like the femur and the humerus, and the answer will be fat embolism. Okay, tension pneumothorax is not the right answer. Pulmonary embolism and myocardial infarction, because the clinical history will be different, because this was also correlated with orthopedics question. So myocardial infarction will have a different chest pain radiating towards the tip of shoulder, left hand side. Tension pneumothorax also. There must be a history of some rib fracture or injury in the lung. Pulmonary embolism is also not the right answer. The correct answer is fat embolism. So the most likely the patient presents with a history of long bone fracture, and after that they are having the patient is having breathlessness, confusions, and breathing problems. So basically the case is of fat embolism syndrome. The characteristic symptom which I am talking about, the respiratory impairment will be breathlessness, tachypnea, neurological confusion will be also present in the patient, and there will be also chance of petechial rashes. So as the clinical history is pointing towards fat embolism syndrome, so the right answer will be A, fat embolism. The image was provided in the MCQ which has been asked. The image was provided, and we have got the right answer, option A, fat embolism. Okay, let's move on to the next MCQ. Now, this image has been shown to you in the class, and it's a very easy one. You have to just see the image and tell me which vein is involved: great saphenous vein, short saphenous vein, femoral vein, or posterior tibial vein. So I just want to enlarge this image. Okay, see here. So this is a case of varicose vein. What is the reason of varicose vein, my dear students? We know that if I am talking about the reason of varicose vein occurs because of incompetent valves. Okay. So generally the blood direction or flow is from superficial vein to deep vein. So this is maintained. Why this is maintained? This is maintained because of the competency of the valves. And most commonly the vein valves which is disrupted and involved is great saphenous vein. And here also, if you will see, the foot, this is showing the foot from the medial aspect. So this is medial aspect of foot. And we know that the formation, I will show you another image where I will describe you the formation of great saphenous vein, which is from the medial end of the dorsal venous arch, and it is also on the medial aspect. So great saphenous vein is involved. There can be incompetency in the short saphenous vein or the great saphenous vein. Here we have will mark here the great saphenous vein as the right answer. In untreated conditions, if it is not treated at time, then what can happen? The patient can also have varicose ulcer, and there are so many tests to confirm it. One is Trendelenburg test, which is confirming the diagnosis. Now here you can see, as I want you to show this image. Why? Because by seeing this image, it will become clear to you that the medial marginal vein. So there is a medial marginal vein, and there is the medial end of dorsal venous arch. So actually medial marginal vein and the medial end of dorsal venous arch are the formative vein for forming the great saphenous vein. Okay. And ultimately the great saphenous vein will drain into femoral vein. So if there is incompetency in the saphenofemoral junction or the vein, it can lead to a condition of varicose vein, dilatation of the vein, and the blood is flowing in reverse direction. The normal flow of the blood is from superficial to deep. If there is incompetency of valve, what can happen? The blood will flow in reverse direction from deep veins to superficial vein. Okay, so there are stripping surgeries, laser surgeries for the correction of varicose vein. Okay, let's move on to the next MCQ, that is MCQ number 9. Identify the marked bone. So it is an easy one and we can clearly identify it. So we can clearly identify it. So we have to just see this image, and this is the arrow. This is the arrow which has been marked in the cushion. So this is the arrow, and arrow has been marked on one of the bone, one of the foot bone, which you have to know. And here we can just have an idea that this is the medial side and this is the lateral side. Why? Because the little toe and the great toe will be on the medial side and the little toe will be on the lateral end. So we have got an idea, and the bone which is sewn. So if I have to highlight this bone and what is the correct answer, definitely the bone is navicular bone. Which bone is this, my dear students? The navicular bone has been asked from you. So this is which bone? This is the navicular bone. Now I will actually show you more images of the bones of the foot so that you can understand the articulation of navicular bone more. So here you can see the tarsal bones, and different colors has been used. So we know that in the foot we have got heel bone, which is called as calcaneum. So here we have got the calcaneum. We have got the talus. We have got the navicular. So yes, you can see this is the navicular bone, and this has been asked in the MCQ. So we know that the navicular bone is on the medial aspect, which is articulating. As you can see, this navicular bone is articulating with talus on the part of calcaneum. So talocalcaneo-navicular bone. So we can form a joint also. Actually, with talus there is subtalar joint and there is calcaneo. There is also another joint which is formed, that is called as talocalcaneo-navicular. So basically, other than that, you can see the three cuneiform bones are also there. So which three cuneiform bones are there? We have got the medial, the lateral and intermediate cuneiform bone. So altogether, if you want to know, we have got seven. We have got total of seven tarsal bone. What are they? The calcaneum bone, that is the calcaneus. Then we have got the talus. Then we have got the navicular, the cuboid, which will be lying more of lateral aspect. This is the cuboid. This is the talus, and here we have got the calcaneum bone. And we have got the three cuneiforms: the intermediate, the medial, and the lateral cuneiform. So together we have got seven tarsal bone, and this was a very easy one. Here I also want you to see the bony aspect. So you can see this is the talus bone from the superior aspect. Actually, the superior aspect of the talus bone articulate with the tibiofibular motives to form ankle joint. This is calcaneum. This is cuboid. This is the navicular bone which has been asked, which is lying medially, and anterior to it we so more you can say more distal aspects. We have got the three cuneiform bones. Also in this diagram we can see the metatarsals and the phalanges. So, okay, this is the right answer, and for the navicular bone. So, everyone must has marked it right because it was an easy one. Now, moving to the next MCQ of the previous year. So, this was again an easy MCQ. Which nerve is injured? So, I think we have discussed this, everyone. Let me just check. Yeah. So, I think we have discussed this. Which nerve is injured in this image? So, we can see a radiological image where the part of the fibula bone neck has been fractured. Whether the nerve injured is common peroneal nerve, deep peroneal nerve, superficial peroneal nerve, or tibial nerve. So let me just enlarge this image. So when I am enlarging it, I want to appreciate everyone. Can you see this line? What is this? This is the fracture line. This is the fracture line which is involving neck of fibula. So this is the fibula bone. This is the tibia, and this is the femur. So the nerve which is winding around the neck of fibula will be the common peroneal nerve, and this common peroneal nerve will ultimately divide into deep and superficial peroneal nerve. Superficial peroneal nerve is the nerve of lateral compartment of the leg, and deep peroneal nerve is the nerve of anterior compartment of the leg. So here the nerve being injured is the common peroneal nerve. Which nerve is injured, my dear students? The common peroneal nerve is injured, and injury to common peroneal nerve means both the component is injured, deep peroneal nerve and superficial peroneal nerve. When superficial peroneal nerve is injured, the muscles of lateral compartment is paralyzed, peroneus longus and peroneus brevis. What will happen? The action of these muscles will be affected, that there will be no everters of the foot. So everters of the foot is injured. Deep peroneal nerve is the nerve of anterior compartment of the leg, and all the muscles of anterior compartment of the leg are dorsiflexors of the foot. That is, there will be paralysis of extensor hallucis longus, tibialis anterior, extensor digitorum longus, and peroneus tertius. I also want everybody. So actually this was exactly the question which has been asked, but I think few of the students has told me, that radiological image was not given. There was a different image which has been used, and you can see if this image was used, you can see foot drop has been shown in this image, and the result of the answer is common peroneal nerve. So either the X-ray film image was given or the clinical image was given. Both way the answer is common peroneal nerve. And here I want you to show the neck of fibula. So here you can see this is the neck of fibula, common peroneal nerve. There will be injury of deep peroneal nerve which is injured, and there will be also common peroneal nerve injured because of the fracture of the fibula or hit on the lateral aspect of the leg. Superficial peroneal nerve will also injured, and it is very important for you to note down that common peroneal nerve has got the root value. It is formed by the ventral if I talk about the common peroneal nerve, it is formed by the dorsal division ventral rami, dorsal division ventral rami of L4, L5, S1, S2, which is dividing into deep peroneal nerve and superficial peroneal nerve. Now here superficial peroneal nerve is the nerve of lateral compartment of leg. And if we are talking about deep peroneal nerve, is the nerve of anterior compartment of leg. And that means in this case where the injury is on the neck of fibula, both parts. Okay, one of the student is telling Madeen, yeah Madeen, I think anatomical snuff box, most common bone fractured has been asked. Okay, so if anatomical snuff box has been asked, so yes, Madin, I will tell you the answer is anatomical snuff box has been asked, and tenderness in anatomical snuff box after outstretched fall, the most common fractured bone will be scaphoid. Is it okay? So the most common fractured bone will be scaphoid. Is it okay? Now see here. After that, if deep peroneal nerve is injury happens, what will happen? All the muscles of anterior compartment will be paralyzed. All the muscles of anterior compartment paralyzed. That means the action of extensor hallucis longus, extensor digitorum longus, tibialis, anterior and peroneus tertius paralyzed. So a common means they are all dorsiflexors of foot. So that means no dorsiflexion. The patient is not able to, so dorsiflexors are paralyzed. That means the patient will have plantar flexed foot. Other than that, superficial peroneal nerve is injured, and when it is injured, the muscle being paralyzed is peroneus longus and peroneus brevis. That means everters of the foot are paralyzed. Is it okay? Okay. So we have done with this. Now moving to the next MCQ, question number 11. At the level of T4, which of the following structure produce physiological constriction of esophagus? I have explained number of times. I have explained number of times. Now, esophageal constriction. So if I talk about esophageal constrictions, it's an important part which you have to know. So we know that constriction level of esophagus happens to be at four constriction. One is cricopharyngeal junction, the other is arch of aorta, the left bronchus crossing, and the esophageal opening of the diaphragm. Among this, the level of T4 constriction of the esophagus, the right answer is arch of aorta. So definitely the right answer is arch of aorta. Okay, so here you can see this is the esophagus, this is the cervical part. So this is the first, so pharynx, this is pharynx. Actually the extent of esophagus is from C6 to T11. Okay, so this constriction, if we talk about, that happens to be C6, and that is pharyngoesophageal junction. Arch of aorta constriction happens to be at T4. Left bronchus constriction happens to be T6. Some books have written T5 also. And the aortic opening of the esophageal opening of the diaphragm is at the level of T10. So basically these are the levels, and here directly arch of aorta level and constriction has been asked. So T4 is the right answer. Here it is also important to know the distance of these constrictions from the incisor teeth. So as I told you, the cricopharyngeal constriction level is at the level of C6, and it is approximately 15 to 16 centimeters from the upper central incisor teeth. Arch of aorta constriction. So arch of aorta constriction will be at the level of T4, and it is corresponding to 25 centimeters from upper incisor teeth. Left principal bronchus is at the level of T5. Some books has written T6. It can vary T5 to T6, and it is approximately 27.5 or 28 centimeters from the central incisor teeth. Esophageal hiatus T10, that is 40 centimeters or 37.5 centimeters from central incisor teeth. So very nicely we have done this, and arch of aorta is the right answer. It was the direct MCQ. Number of times this question has been repeated in the previous year of FMG notes also we have discussed, and this question I have discussed so many times. I hope everyone has given the right answer. Okay, so can anybody tell me which procedure? This also I have explained. If I remember the lower limb session, there many of the students has told me, ma'am, in orthopedics also Lachman test, anterior drawer test, posterior drawer test has been done. So please explain it. So we have completed this test, and which test is this? Anyone give me the right answer? So this is drawer test, and this is done for the and so this is the anterior cruciate ligament. So anterior drawer test. So actually this image was given, and you have to just identify. So actually anatomy is a subject which is integrated with surgery, which is integrated with orthopedics, and so it's very important that you should go through the clinical subject. There also anatomy questions has been asked. This is anterior drawer test. So there will be a clinical note, and you have to identify. So the test being performed is anterior drawer test. Anterior drawer test is a physical examination which is done for the assessing the anterior cruciate ligament injury. So it involves the doctor or healthcare worker. So forward force the tibia, that is anterior forcing the tibia while the knee is bent. The bending of, please mark it, the bending of knee is 90 degree. If there is an excessive forward translation of tibia, relative to that of the femur, it suggests that this is a case of potential ACL tear. What is ACL tear? Anterior cruciate ligament tear. Now, there is another modified, which is a modified form of anterior drawer test, that is called as the Lachman's test, which I will discuss. The interpretation of anterior drawer test is it can be either positive or negative. So when it is positive, when there is increased forward movement of tibia, then it is suggesting ACL tear. If there is no significant forward moving of the tibia, its interpretation will be the anterior cruciate ligament is not injured and it is intact in the patient. As I told you, there is a modified form of anterior drawer test, which is also very, very important for you to know. So the modified form of test is there, which is very important for you to know. It's the Lachman test, which is also used to assess the integrity of ACL tear in the knee. So in this, the bending of knee is 30 degrees. No, so please note down, the bending of the knee is just 30 degrees and it is done in acute conditions. It is more reliable and more sensitive in detecting axial tears in acute phase. So pulling the tibia forward while stabilizing the femur, and the bending of knee is just 30 degrees, and if there is excessive forward translation of the tibia, then this will be a case of axial tear. Okay. So the image was provided and you have to guess the test being performed, and the right answer is anterior drawer test. Okay. So I think everyone must have marked it right. Let's move on to the next question. Okay, dear, let's move on to the next question. Question number 13. A person had loss of sensation on the lateral 3.5 of the finger. Which nerve is involved? So this kind of either a clinical question was there with a clinical history. Exactly the words I can't get, but the loss of sensation in the lateral 3.5 of the fingers. So which is the nerve involved? So medial nerve, ulnar nerve, musculocutaneous, axillary nerve. So I think you are knowing the right answer now. How? Why? Because we know median nerve is responsible for giving sensation on the lateral 3.5 of the fingers and the palm. So the right answer is median. Okay. Why not ulnar nerve? Because it is giving innervation to the medial part of the palm and medial 1.5 fingers. Why not musculocutaneous nerve? So musculocutaneous nerve is not the right answer because it will give a cutaneous nerve, that is lateral cutaneous nerve of forearm, and it will not supply the hands. Axillary nerve will give cutaneous sensation over the skin over deltoid muscle. So we will have the right answer as median nerve. The characteristic key point which is important for us to note is the loss of sensation is on the lateral 3.5 of the fingers. So the nerve involved will be median nerve. So I have already explained the cutaneous distribution of the nerves of the hand on the dorsum and the palmar aspect. So it is easy for you to solve. So you can just see another image. Actually, the transverse section of the wrist has been shown. So here you can see this is the median nerve. Okay. And here you can see this structure is the transverse carpal ligament, that is the flexor retinaculum. So we can clearly see in this condition that median nerve is passing beneath flexor retinaculum or transverse carpal ligament, and it is compressed in the case of carpal tunnel syndrome. So there will be tingling sensation, there will be pain on the lateral aspect of the hand, and in the lateral 3.5 fingers. Sometimes the pain is so much that the patient can't sleep in the night. So in that cases we can go for surgical release of the flexor retinaculum to relieve the patient. So basically the hint which was given was the loss of sensation on the lateral 3.5 of the fingers. So we will have median nerve as the right answer. Now, one of the question was, what is the nerve of piriform fossa? Okay, either a clinical note. So piriform fossa, it is very important for you to know what is piriform fossa, what is piriform sinus, where it is located. So it is a lateral food channel. It is a lateral food channel. And actually it is located lateral to the laryngeal inlet. What is the location? It is located lateral to laryngeal inlet. And an important nerve is traversing through piriform fossa or sinus, which is very important for you to note down. So actually, there were so students were telling that there was a question from Students were telling me that there was a question from the piriform fossa. So I have framed one clinical, exact word would not be same, but I have framed the clinical note for you so that it will help you to understand the right answer. Something like this. So the students like Madin, Udan, Abhishek, they can help me if they are remembering the exact language of the question. So basically here, a 60-year-old man presents with a swelling in the neck. A biopsy of benign tumor was done from the piriform recesses of the larynx. Okay. The mucosa of the piriform recesses must be anesthetized during the removal of the tumor. Which nerve supplies general sensation to the mucous membrane of laryngeal vestibule and piriform recesses? So that means we have to know the anatomy of piriform sinus, and we have to know the nerve which is traversing through it. So if I divide the laryngeal cavity, upper and lower part, the upper part or the piriform sinus is getting innervation from sensory innervation from internal laryngeal nerve. And internal laryngeal nerve is a branch of superior laryngeal nerve. If I'm talking about the lower part, below the vocal cords, the lower part of laryngeal cavity is getting sensory innervation from the recurrent laryngeal nerve. So the right answer is internal laryngeal nerve. Superior laryngeal nerve divides into internal laryngeal nerve and external laryngeal nerve. Here, external laryngeal nerve will give innervation to cricothyroid muscle. It is just a motor. It is a motor nerve, motor branch. And internal laryngeal nerve will give sensory innervation to piriform recesses or sinus. Now, here we can see the mucous membrane reflected, and you can see internal. If I enlarge this, you can see clearly the internal laryngeal nerve is giving sensory supply to piriform recesses or piriform sinus, which is clearly visible in this image. It is giving sensory innervation to piriform sinus or recesses. Okay. Now here I also want to show you this image where you can appreciate here. Okay, this is the laryngeal inlet. What is this? This is the outline of laryngeal inlet, and lateral to it, we can see the piriform sinuses on the either side. I'm just highlighting this. Okay, lateral to it is the piriform sinuses, and piriform sinus medial and lateral wall has to be appreciated. It's very important that piriform sinus or fossa boundaries should be known to you. So medially it is bounded by aryepiglottic fold, arytenoid cartilage and cricoid cartilage. Laterally by the thyroid membrane and thyroid cartilage. Superiorly by the lateral glossoepiglottic fold. Inferiorly it is continuous with the esophagus. So sometimes fish bone foreign body get impacted in the piriform sinus, which is having medially, it is having the aryepiglottic fold, arytenoid and cricoid cartilage. Laterally it is having the thyroid and thyroid membrane. And so basically what happens in during the removal of fish bone also, precautions should be taken that not to injure internal laryngeal nerve. Why? Because if it is injured, the protective cuff reflex will be gone, and it is very important for the food channel to be maintained, food to go towards the pharynx and not towards the larynx. Okay. Now one of the question was, let's move on to the next question. So one of the question was about singer cannot raise the voice post thyroidectomy. Okay, so we know that thyroid gland, if I'm talking about thyroid gland is having arterial supply as superior thyroid artery. This also we have done in our classes, and it is having another arterial supply by inferior thyroid artery. Now here inferior thyroid artery run close with the recurrent laryngeal nerve, and superior thyroid artery is running close to the external laryngeal. Singer is not able to raise the voice. That is the tensioning effect of the vocal cord has been gone, and that is the action of cricothyroid muscle. And what is the nerve supply of cricothyroid muscle? External laryngeal nerve. So in this case, external laryngeal nerve is injured. So if the patient is not able to raise the voice after the procedure of thyroidectomy, that means particularly the nerve being damaged in this case is external laryngeal nerve. And as I told you, when the superior thyroid artery is giving arterial supply to the thyroid gland from the apical aspect or apex, it is lying close to the external laryngeal nerve. So while ligating superior thyroid artery, precautions should be taken not to injure external laryngeal nerve. What will happen if the external laryngeal nerve is injured? The muscle will be paralyzed. Which muscle? Cricothyroid muscle. And what will be the result? The tensioning effect of vocal cord has been gone. So got it? Okay, are you understanding? Okay. So let's move on to the next. Which nerve fibers carry pressure sensation? Okay, direct MCQ, maybe solving the physiology part also. Which nerve fibers is carrying pressure sensation? So the right answer is A, beta fibers. So A beta fibers are myelinated. So A beta fibers are myelinated fibers, and this is actively responsive. This is activated by stimuli like light touch and pressure, hair movement, and here pressure sensation was given. So obviously it is a direct MCQ. So the right answer will be A beta fibers. Okay. So activation of A beta fibers can even help to close the pain, and it is responding to the stimuli like light touch, pressure, and hair movement. The A delta fibers are smaller, thinly myelinated, and they are stimulated by sharp pain and temperature and also cold. Okay, also cold. So they are responsible for fast pain and contributing to withdrawal reflex. So all of you should know about the function of A delta fibers and A beta fibers. So the right answer here will be A beta fibers. Is it okay? Okay, so just two more MCQs, just two more. We are going to end now. Don't worry. What is the remnant of the? So this was an embryology question where there was an image given, and the students were telling there was an arrow marked on the structure close to neural tube. So here it is neural tube, and close to it we can see the notocode. So if the question mark is over the notocode, and you have to tell me the remnant of notocode, the right answer will be nucleus pulposus. So notocode, so here you can see, actually when we were doing the during gastrulation, after that we were also talking about neuralization, that is the formation of the neural tube and notocode. So notocode remnant during embryological development, it will give rise to the nucleus pulposus. So the right answer will be nucleus pulposus. Is it okay? Now okay, now I want you to tell last question. Okay, the last question. What is the case which is shown below? So in this case, the umbilical hernia. It's a very easy one. It's a very easy one, and the right answer here will be umbilical hernia. This is which has been asked in the surgery question. So this is the diagnosis of umbilical hernia. The cause of umbilical hernia in infants is why there is herniation through the umbilical ring, the opening of the abdominal wall. The umbilical cord is passing. It is not completely closed after the birth, and in adults also it can happen if the multiple pregnancy, obesity, or persistent coughing is there. Then also there can, due to increase intra-abdominal pressure, umbilical hernia can happen. Okay. So my dear, we have done with this. We will again meet with more of online sessions. So I think I have described all the anatomy question related to FMG examination. All the best, and I know you are going to get through it, and be positive. Thank you so much. Thank you, my dear students. Thank you.